There we go. All right, we're going to get started here in a second. Welcome, everyone. On behalf of the Centers for Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. My name is David Saltzman, and I work for Kaufman Associates. I'll be your moderator today. Today's webinar is Managed Care and Home and Community-Based Services. Before we begin, I would like to highlight the main features of your Zoom webinar interface. First, the presentation slides will appear in the main window, while the speaker is in the top corner. At the bottom of your screen is the menu bar. Here you'll find the chat, raise hand, Q&A, and closed caption functions. Please use the chat box to report any technical issues you are experiencing. We will respond to these concerns as they come in. Next to the chat box is the raise hand feature. You're able to use this during the Q&A segment to let us know when you'd like us to unmute your mic so you can ask a question. Another way you can submit a question is the Q&A box itself, where you can leave a question at any point during the webinar for the presenters to address during the Q&A segment at the end. Lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. Please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. With all that said, I would like to welcome everyone to today's webinar. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. I would like to introduce our presenter, David Larson. Mr. Larson is a Director of Continuum Care for the Oneida Nation. Please go ahead.
Next slide, please. This is our agenda for this afternoon. We're going to be talking primarily about the Oneida Nation's journey that we went through from a fee-for-service home and community-based waivers program to a managed care program under Section 1915B of the Social Security Act. I hope that you find this presentation informative and useful. Next slide, please. To start with, the home and community-based waivers that we're used to right now didn't exist until 1981. And that, as long ago as that seems, was 40 years ago. But for those of us who were still around back then, this was a really big change in the way services were provided. President Reagan signed the legislation in 1981, And it changed the way home and community-based services were able to be presented by the states at that time. Previous to this, almost all waiver services that we know now were either not available in some states at all, or in some states, they were very limited in nature. Most of the services were, in fact, institutionalized services, be they in hospitals or nursing facilities or institutions of intermediate care, primarily for people with mental health diseases and mental retardation. Next slide, please. Wisconsin, just like a number of other states, started looking at how to perform these services shortly after it was announced by President Reagan. So the Wisconsin program actually started as the Community Options Program in the early 1980s, and it operated very, very successfully for quite a number of years. During those early years, the program was actually operated at the county level, and the counties were designated as lead agencies that were charged with discharging all the services on behalf of the state. However, in the early 2000s and going into the mid 2000s, Wisconsin began to see a number of issues with the current waiver program. The first one of those was that to some extent, the program was a victim of its own success. While money didn't necessarily increase at the rates that everybody wanted it to, the numbers of individuals signing up for these services increased almost geometrically over the years. And that became a problem as far as state budgets were concerned. At the same time, a lot of individuals were starting to look at what was going to happen in not that many years when all of the baby boomers started to come of age and actually started to need all of these services that were already beginning to put huge strain on the state's budget. So the state did begin programming to go into managed care. They completed that transition June 30th, excuse me, of 2018. Next slide, please. Oneida originally didn't participate in the waiver program as a service provider. Oneida, being a reservation that straddles two separate counties, relied on the counties to provide all those services for the tribal members initially. However, it was discovered as time went on that the counties weren't necessarily providing the level of services to the tribal members that the Oneida Nation thought we should be getting. So based on that, the tribe applied to the state of Wisconsin to operate the program on the same level as the counties did as a lead agency. The state did take that application and was very happy that the Oneida Nation was able to move into actually providing managed care. One of the things that we were concerned about, however, once the state began to talk about moving into managed care, was going back to the early 1980s and 1990s before we had our own services. Initially, services went well, as I mentioned before, but then services started to become fewer and fewer, especially for those folks further out in the counties and the rural areas. All of this came back up to the forefront as managed care in 1915B was being discussed. We also ran into a number of realizations that really kind of shook everybody up as the state was discussing how these services were in fact going to be provided underneath managed care instead of under the fee-for-service system that they had been based on for the past 25 years or so. Next slide, please. Just a very quick overview of what the 1915C waivers did. And this is what set up home and community-based waivers to begin with. When you look at the Social Security Act, there are a number of things in there that apply to the regular Medicaid system. So in order to set up these home and community-based waivers, one of the things that had to be done away with as far as requirements that existed in the Social Security Act was that the services had to be A, statewide, B, that those services had to be comparable for everybody across the state who was in need of those services. That by definition created a problem, since these services were meant to be targeted, at least initially, for those people who were in those institutions that we just discussed earlier. The third thing that it did was change the income and resource rules for people participating. Next slide, please. Now, talking about Section 1915B, which is where we're going to spend all of our time this afternoon. It does a number of different things. And once again, this was part of the legislation that President Reagan signed way back in 1980. But it originally wasn't used all that much. Since the 2000s, more and more states have beginning to look at 1915B waivers as a way to move into managed care. And typically you're going to see this both in home and community-based services, as well as they're starting to do this quite a bit for behavioral health services as well. There are a number of different authorities that this provides the states. The two big ones that we're going to be talking about today are the first one, which mandates that individuals who want services have to be enrolled in managed care. There's a couple of other ones, but the other one that's really important for us in our discussion today is this allows the state to limit both the type of service providers as well as the number of service providers that are eligible to contract with the state underneath this waiver. Next slide, please. There are two things that some people sometimes get confused when we're discussing these waivers. The very first one is, as we just discussed, one section says that individuals have to join the managed care organization if they want access to these services. Unfortunately, there's no way around that for tribal members. If tribal members want these services under this waiver, they have to join the MCO. However, where there is a difference is in 1915B Section 4. Even though the state does have the option, which they exercise very freely, to limit the type of organizations that it's going to contract with, as well as the total number of organizations that it's contracting with to provide these services, that does not affect tribes. And specifically, it does not mean that the tribes lose their ability to provide services with or without contracting with the MCO, whichever region they happen to be in. The way that these are typically set up is the state will divide its state into different regions and contracts with different managed care organizations for the separate regions. So you may have one or two MCOs that provide services in one county or one section of the state, but not in the entire state. Next slide, please. When a tribe finds itself being in the situation that the state is moving to 1915B waiver, there are four options, speaking in really big buckets, that the tribe has a way to participate or not participate. The very first one of these is the tribe has the option not to participate at all. The tribe can, in fact, let the MCO provide all the services to its tribal members and not provide any services or get paid for any services whatsoever. Obviously, almost all tribes are going to find that unacceptable. The second thing that the tribe can do is create its own MCO. Now, we do have tribes throughout the country that have created their own MCOs for providing both primary and acute care on the medical side of the house. That unfortunately takes a lot of resources and capacity on the part of the tribes. And not all tribes, matter of fact, very few tribes actually have the ability to do that. But the tribes that have created MCOs have been very successful in doing so. But to do so does take a lot of resources and is usually very stressing on tribal resources. The third option that the tribe has, and this is actually what most tribes end up doing in this situation, is contracting with the MCO and essentially becoming a subcontracted service provider to the MCO. Now, in this case, what happens is the tribe becomes a subcontractor. They're not in control of the services that they provide. The MCO will dictate how the services are provided and under what circumstances. But once again, this is typically the situation most tribes find themselves in. The fourth option is what Oneida decided to do, and that was to go ahead and negotiate an entirely separate agreement with the state and with the MCO, such that the tribe actually ended up with a lot of control over the services being provided to its community members. Next slide, please. When you have the typical capitated relationship with the MCO that we just talked about, that most tribes find themselves in, these are some of the issues that you end up dealing with. There's a direct contractual relationship that's put into place between the state and the MCO. There is a tribal contract that will exist as a subcontract to that main contract between the MCO and the state for whatever services the tribe decides to provide. Now, those who are familiar with it, home and community-based services have this whole large array of services. And the tribe may decide it wants to provide a lot of those services, and maybe it only wants to provide a few of those services, such as transportation, for example. Being a subcontractor, the tribe will not make the decision how many of those services get provided to its tribal members. That will be done by the MCO through a case management function. The next thing that's going to happen is the government-to-government relationship that would normally exist between the state and the tribe goes away. And we'll show that very clearly on the next slide, please. What basically happens is, instead of the tribe and the state having a direct government-to-government relationship, you've now taken and imposed this MCO right in the middle of all the operations. So there's no longer a government-to-government relationship. And you've also created a situation where, in order to get services to community members, instead of going just between the tribe and the state, now the community member has to go through the MCO. So from a number of standpoints, to include tribal sovereignty, as well as just plain getting services to tribal members, this obviously is not the best type of relationship to have. Next slide, please. Under the new capitated system and relationship that we decided to negotiate, things changed quite a bit. We maintain the direct relationship between the state and the MCO. That's required because the MCO is still providing services for non-tribal members. However, we now maintain the government-to-government relationship because a contract is going to be between the state and the tribal health facility. The tribe also is not going to be subordinated to the MCO, since we're going to have a direct relationship to the state in this instance. Now, it does mean that a number of separate agreements have to be made. There were basically two agreements that were very hierarchical in the relationships in the past. There was one contract between the state and the MCO, and a separate contract between the MCO and the tribe, with the tribe being the subcontractor. Here, we're going to have an agreement that exists between the tribe and the MCO, and that is going to exist primarily to define how daily operations work and how information is going to flow back and forth between the tribe and the MCO. And we'll see that very clearly on the next slide, please. Here you start to see the difference where we still have that direct relationship that now exists not only between the state and the MCO, but between the state and the tribe, maintaining a government-to-government relationship. There's also that agreement I discussed between the MCO and the tribe. Now, if anybody's ever read a MCO contract with a state, those usually run somewhere between 300 and 500 pages long. Now, the contracts between the state and the tribe and the MCO and the tribe don't necessarily have to be that length, but they're going to cover a lot of the same areas. And so whenever a change gets made to one contract, you're probably going to have to end up making changes to the other two contracts. So in order to make this situation work, you've really got this triad of agreements that has to be put in place. So the other thing you're going to see down here underneath both the MCO and the tribe is case management. And I mentioned that very briefly a little earlier. Case management in this situation becomes absolutely vital because the case management determines how services get provided. And we'll talk more about that right now. Next slide, please. One of the primary things that the MCO does is provide case management services. So you've got an IDD team that is usually comprised of a nurse and a social worker and possibly some other providers. But that is normally determined by state law. There are some federal regulations that have input into that, but nurses and social workers are typically found. Those case managers meet as a team and determine on an individualized basis what every member of the MCO needs for services and how those services are going to be provided. So they come up with an individualized care plan for each individual. Now, the importance of case management, I cannot stress enough, because this is really where the control in this all is. As I stated before, the tribe has the option to provide any services, be it transportation or home chore services or any service, but unless they control case management, they don't have control over what the tribal member really is going to end up with as far as services. And just to illustrate that, and show you really how important it is. After we moved into this managed care agreement with the state and the MCO in our region, we had a tribal member from literally the other side of the state of Wisconsin contact one of our case managers. And the woman's mother was currently receiving case management services from an MCO literally on the other side of the state. And she said she realized that we couldn't provide services for her, even though she was a tribal member, just because she was so far outside of our service area. But she didn't think that the MCO was providing the services that her mother really needed. And she asked if we would be so kind just to go ahead and perform an assessment from our case managers to see what we thought her mother needed for services. And we said, as long as you understand we can't provide them, we're happy to do that for you, which we did. What we found was that the MCO in the area she was living in was providing home care services for her mother 3 times a week for a total of 2 hours per day, for a total of 6 hours a week. When we did the assessment, we determined she actually needed a full 40 hours of services in home during the week. And had she been in our service area, the tribe would have in fact provided 40 hours of services. That's why the function of case management becomes so absolutely vital. The case managers do the assessments, they determine what services they will authorize, they determine how those services are provided. Now, one of the things that if the tribe wants to go ahead and provide case management services, it's got a couple of things that it can do. One of those is, since the case managers actually determine how services get provided, the tribe has the option of either using service providers that the MCO already has under contract, or the tribe can actually go out and get their own contracts with different service providers if they would choose. Now, once again, this is where providing case management becomes very intensive. And unfortunately, not all tribes have the ability to perform the case management services just because they're smaller, they don't have the financial capacity, and they don't have the experience to do so. So they can still provide services as a service provider, but really controlling what your tribal members get is really this case management function. Next slide, please. Once you decide that you would like to go into this type of arrangement and you start discussing it with both the state and the MCO in your area, both the state and the MCO are immediately going to bring up some very large concerns. The first one is, who holds legal liability? And that's a loaded question and a really big one. And we'll spend some time discussing this in more detail very shortly. But since the law is dictating that the tribal member has to enroll in the MCO becomes legally responsible for the services that are or are not provided to that individual. That is a really big problem to get over, but it's solvable. It's not insolvable. But when you start to first bring this up, it's a huge concern for both the MCO and the state. The other thing that comes up is, how is the MCO going to be made financially whole? And this becomes very important for a couple of reasons. The first reason is the same reason that FMAP and 100% FMAP is so important when we talk to the states about providing services. Congress, as you know, passed 100% FMAP into legislation because states were very hesitant to provide all the services tribal members needed, because part of that was state money. The idea of 100% FMAP was to have the federal government, at the end of the day, pay the state back for those services, so there was no state money whatsoever going into the services for tribal members. And hence, there would be no disincentive for the state not to provide services to tribal members. The same philosophy applies to the MCOs. Since the MCOs, according to federal law, have to have risk, meaning they have to run the risk of losing money and having a net loss at the end of the year. Being able to make sure that they're made financially whole does exactly the same thing that 100% FMAP does for the states. And the way this ends up working is the MCO actually keeps track of all those costs. They give them to the state at the end of the year, and the state takes and submits those to CMS and receives 100% FMAP. So both the state and the MCO are made whole, which takes away all the financial disincentive not to provide proper services. The second reason that this becomes very, very important, and this comes up at national level meetings, be it TTAG or tribal self-governance or STAC, all the time, is by making sure that both the state and the MCO get made financially whole at the end of the day. What it does is put the responsibility back on the federal government to fulfill its treaty obligations to provide the tribes with health care. If the MCO would end up, or the state would end up, providing some of these services and paying for them, it basically lets the federal government delegate those down to a lower level. And all of the treaties that the United States signed with tribes say that the United States government, not the state government, not the MCOs, are responsible for providing those healthcare services. Next slide, please. This is where, once you get to this part of the negotiations with the state and with the MCO, you're going to start running into a lot of very, very detailed information and technical discussions. And this really gets back to the fact that the MCO is still legally liable and holding liability because the tribal members are actually enrolled in the MCOs. The MCOs are still going to have a lot of statutory reporting that they are required to make to a number of organizations, to include the state. So with the tribe now providing and being in charge of some, if not a great deal, of the operations for the MCO, there obviously has to be a huge amount of information that has to go back and forth between the tribe and the MCO on a daily basis. Now, that sounds a whole lot more complicated than it really in fact is. Because if you really stop and think about it, most of our health facilities are already doing this on a day-to-day basis already with the providers that we have in common out in our various communities. So if we don't have a full array of services at our health center, we take and contract with providers out in the community all the time for things like cardiology and oncology, hospital services for those of us who don't have an IHS hospital, and so on. So this is really, once again, when you really think about it, simply a good coordination of services and a good actual putting into practice case management. But there is a lot of detail, And the lawyers, I flat out guarantee, are going to be involved in this because of potential liability issues. The second thing that's going to come up, obviously, is money. There is going to be a lot of discussion about who pays what, and we'll get into that a little more on the next slide. But rate setting, how those rates are set, and who pays what is going to be one of the main topics that have to be dealt with. The final thing that you're really going to have to put a whole lot of work into is the entire billing and payment process. It could be easy, depending on what the state and the MCO want. It could unfortunately get a little bit more complicated. Next slide, please. As far as the rates are concerned, we run into a problem that these rates have to be completely and totally negotiated. If you look at the primary and acute care side of the health facilities now, there are a whole set of federal payment levels that can be utilized to reimburse the tribes. A lot of tribes look to the O&B rate set by the Office of Management and Budget, otherwise typically known as the all-inclusive rate. Sometimes for some services, Medicare rates are used. For those of you who might be a federally qualified health center, the federal government publishes FQHC rates and PPS payments for FQHCs. The problem is Indian Health Service does not provide long-term care services. They authorize them for the tribes to provide, but IHS doesn't provide them. So IHS doesn't have any rates. Medicare does not cover long-term care services. So there are no Medicare rates to fall back on. The home community-based services aren't an FQHC services, so they don't qualify. So when you look at what the health centers are going to get reimbursed, there's a real question about what do you use because there's no federal standard. And the rates that are paid between the states vary all over the place. Some states have set up very fair rates. Some states have set up rates that you would think are determined to force service providers out of business and not provide the services. So the entire thing about rates has to be negotiated between the state, the tribe, and the MCO. Next slide, please. This is where you get into who's going to pay what. So regardless of what the rate is, the state has the option to pay the entire bill. Now, if the MCO pays part of the bill, which is frequently what happens, what'll happen is the tribe will take and submit an initial bill to the MCO, and the MCO is required to pay the tribe the same rate that it pays other service providers for the same service. That typically is going to be way short of what it actually costs the tribe to provide the services. So as many of you know, and this happens on the primary and acute care side of the house as well, the state's required to pay a wraparound cost that makes up the difference between what the MCO would pay and what the total cost is to the tribe to provide those services. So you've got an argument that's probably going to occur because whoever pays bills does more paperwork. So if the state pays the entire bill, both the initial bill and the wraparound, the state's going to end up doing most, if not all, of the paperwork. In our case in Wisconsin, the state didn't like that idea. They thought that both tribe and MCO should do at least some of the paperwork. So what we negotiated was that we would send the bill to the MCO. The MCO would pay the initial bill just like they would to any other provider. And then the state would pay the wraparound at the end of the year. Some states do have a problem with paying on time. Having said that, a lot of MCOs have a problem with paying on time. So you're going to have situations where, depending on the state, depending on the MCO, a tribe might want the state to pay because the state will pay on time. You might want the MCO to pay the entire bill because some MCOs actually pay faster than the states do. But once again, this is where that negotiation is going to come in. And once again, if either the state or the MCO pay the entire bill, they're going to end up doing most of the paperwork. There'll still be some paperwork the tribe has to do, but it won't be nearly as much. Next slide, please. The next thing that's going to come up in regards to payments is whether or not a tribe has to do a cost report. Nobody who's ever done a cost report likes looking forward to doing cost reports. They're lengthy, they're complicated to do, they take a lot of time, and take a lot of tribal resources to finish. And then the states may or may not get around to auditing those and paying you in a timely manner. Here in the state of Wisconsin, the state is typically, for most of the tribes, about 2 to 3 years behind in auditing cost reports. So whether or not to do a cost report, unfortunately, is going to be largely dependent on what you can negotiate both with the state and with the MCO, and how the state and the MCO are going to take and iron out what the MCO gets paid to make them entirely whole at the end of the year. If the state pays the entire bill, or if the MCO would end up paying the entire bill, there's a higher likelihood that the tribe will not have to do a cost report because those two entities are already going to have all the data that they need that the tribe would actually put on a cost report. Now, if you're in a situation like we are here in the state of Wisconsin, where the MCO pays part of the bill and then the state pays the wraparound, the likelihood of having to do a cost report increases. It's still not the total, or guaranteed, I should say. It's still not guaranteed that you'll have to do a cost report, but it is more likely that you'll have to. If you happen to be an FQHC, FQHCs are required to do a cost report. In this case, your likelihood of having to do either an addendum to your FQHC cost report or a separate cost report for reporting purposes, both to the state and to the federal government, is probably quite high. Next slide, please. Now I want to spend some time talking about a lot of the different problems that we encountered and how to solve some of those issues. Next slide, please. The very first problem that we encountered was negotiations and tribal consultation. As you know, states have different histories with the relationships with tribes. Some tribes have very, very good relationships and very good consultation agreements with the state. Some, unfortunately, are not so great. Even if you're in a state where you have very good relationships with the state, those can change very quickly when state administrations change. We ran into some of these issues here in Wisconsin. Fortunately, with both Republican and Democratic administrations, We didn't run into too many problems, but we did run into a few when administrations changed. If you don't have the ability to get meaningful consultation with the states on this issue, the good negotiations simply aren't going to work. The tribe has to get to a point where you can discuss this with the state on a meaningful consultation situation. If you're running into problems, you do have the option, as most of you know, to contact CMS to have state negotiations directly between the tribe and CMS if you're running into a problem with the state. Next slide, please. It's difficult to have any kind of negotiation without running into communication problems. When you start discussing all the technical detail that you're going to have to discuss under a 1915B waiver, and who's responsible for what, and how liability gets determined, and all of these very legal technical things, it's very easy for people not to be clear and concise in their terminology. We unfortunately learned that the hard way. We would have meetings and we would leave the meeting where everybody thought it was a good meeting, the state, the tribe, the MCO, and we all thought we were on the same page. Only to find out several weeks or a month later, when we started exchanging documents, that we didn't agree on anything. And one of the biggest things we found was we were all using the same terminology, but in vastly, vastly different ways. And so what we ended up doing after we'd gone through this, and a lot of people got very, very frustrated, we thought it would be common sense to go ahead and write a lexicon or a glossary. We found that to be very useful. And after we did that, we said, okay, we realized that state, when you're talking to your folks in the state or at the federal government, you might not use these terms in this way. And we realized that for the tribe, we might not use these terms in this way at home. And the same thing for the MCO. But for purposes of these negotiations, when we use these terms, this is exactly and precisely what they mean. We could not believe how much difference just writing that glossary and defining terms actually meant, and how easy negotiations actually were after that, with people actually understanding what everybody else meant. Next slide, please. The other big thing that I know all of you at one time or another have run into is education. You're running into an issue where probably most people that are going to be negotiating with the state don't know any, if any, of the laws and federal regulations that pertain to tribes. You're going to have tribal staff that may or may not know all the regulations and laws. And certainly there are going to be staff from the MCOs that don't know all the specific laws that pertain just to the tribes. So there's going to have to be a whole great deal of education that needs to be done at the very outset to get everybody on the same page. That's going to obviously take some time. But to be honest, that's not really a big problem. It's a large inconvenience. What the big problem is the staff turnover and the need to keep re-educating staff. Everybody, be it the tribe, be it the state, be it the MCO, people are naturally going to retire. They're going to move on to different positions. And you're going to have to continually do this education over and over and over again. And anything that you can do to include that lexicon and glossary I was discussing earlier, anything you can do to speed that education will be of great help and ease everybody's stress. The problem is, and we actually did run into this issue, that education, depending on the rate of turnover, can last literally years and extend this entire negotiation process out literally by years if you've got a lot of staff turnover. Next slide, please. That's the end of my prepared comments. I wanted to make sure I left enough time because typically when we talk about managed care in any setting, everybody has a lot of questions, and I wanted to make sure we were able to get to all the questions.
All right. Thank you very much for that. This is our time for questions. We're first going to address those already submitted in the Q&A box located at the bottom of your screen. So if you have not submitted yours yet, please do so now or use the raise a hand icon and we will get to you if time allows. We'll unmute your mic so you can ask your question. The first question is from Sarah Candelaria. I hope I pronounced that right. So if the tribe decided to do their own home care contracts, would they become a home health agency within the tribe?
I want to specify a little, and once again, here's where clear communications is vital. The tribe does not have to become an MCO. Now, if you're talking about a home care agency, such as a home health agency, the tribe may want to do that. And the reason for that is for certain services that might be provided in the home, they can only by law be provided by and billed for underneath a licensed home health agency. So if you're speaking specifically about that, that's something the tribe may want to do. If you're talking about actually becoming an MCO or creating some other type of organization, other than just the tribal health facility, the answer is no, you don't have to.
And then we had one question from Paula Hunt. Ms. Hunt, if you could, if you're still with us, clarify exactly what you were meaning by your question. She had something to ask about whether the case manager being separate from the MCO for it to be a fair evaluation. And then the remainder of the comments seems to have cut out. So if that, Mr. Larson, leads to you to any sort of insights, that would be a good jumping off point.
Oh, yes, it does. I think I know exactly what you're asking with that question. Typically what will happen is, and I'll just tell you the way it's set up here in Wisconsin, but most states have a very similar type of thing that they go through. The MCO or the tribe doesn't do usually an independent evaluation to begin with. As a service provider, they will eventually do either a change of condition evaluation or an annual or semi-annual evaluation. So they will eventually do them, but it is not uncommon at all for the initial evaluation to be done by a separate entity, either from the state or contracted by the state that does not work for either the tribe or the MCO. And that's done specifically to make sure that the MCO isn't taking and providing more services and billing for more services than the individual might actually require. So for those of you who might be familiar with billing in the clinic setting, it would be the equivalent of trying to prevent upcoding from, say, a level 2 visit to a level 3 visit.
We have another question from chat from Nancy Grubb asking, how do we get in contact with an MCO in Colorado that could provide home care agency services?
Unfortunately, I couldn't I don't have the answer to that. If you contacted someone from the State Department of Health Services for Colorado, they could most definitely put you in contact.
It looks like we have a couple more in the Q&A box, and then one with a raised hand. Another one from Ms. Candelaria. For everything that's been presented, is this the common practice and process in every state, New Mexico in particular?
All the states do have some sort of home and community-based program. Not everybody is, not all the states have a managed care program. Some of them still have a fee-for-service program, just like Wisconsin used to. But because of the baby boomers starting to come of age where they need these services, because of the increased cost of the state budgets, more and more states are in fact looking to move towards some sort of managed care for both home and community-based services, as well as splitting off a lot of behavioral health services. So they're not all doing it. They're all providing some sort of service, but they're not all managed care.
Question from Sarah Caron in chat. What do you think are the key differences for the HCBS recipients under the different types of MCO or tribal arrangements?
The biggest difference, and if there's any MCOs listening, I apologize because I'm going to oversimplify a statement. If you look at the way MCOs operate, they have to operate under a risk-based contract. And that means they have to be at risk of losing money. They're a business and they have to make money and a profit in order to stay in business, just like any other business. Now, on a very, very simplified level, and this is where I apologize if there are any MCOs listening, because I know this is oversimplified, so don't send me hate mail. Basically, if you look at what an MCO has to do, on the one hand, they get paid a capitated payment per member enrolled, and that's where all of their revenue comes from. They have to balance that against, once again, very simplified, the services that they authorize and what they pay for any contracted providers that they have to provide those services. So let's say that, just to keep the numbers simple, let's say that an MCO has a total capitated payment of $1,000 from whatever state it has to be operating in. And it's got two members it's providing services for. The total amount of services that it provides and the rate that it pays its service providers has to be less than a total of $1,000 if it's going to stay in business. If it spends more than $1,000 to provide those services and to pay for those services, they're not going to be around very long. And a lot of MCOs throughout the country have in fact run into that exact same problem. There are a lot of MCOs providing long-term care services throughout the country that have either gone out of business because they can't make it financially, or they've simply been forced to merge with other organizations. But in a simplified manner, they have to make money. So the only two options they have really at their disposal is not authorize as many services, or if they do authorize the services, not pay service providers, be they a home health agency supplying home health aides or nurses. Perhaps it's the contractor that they've hired to cut grass or shovel snow. Perhaps it's a transportation service. So it's basically not providing what the tribe would provide service-wise, or paying wages and contract rates that contractors might not find accessible, allow them to stay in business very long themselves. And most states do run into that problem at some point. The formula that figures those capitated rates is very, very complex. It's very long. There's a lot of things that go into it, everything from labor rates from CMS for different regions of the country, all the way through what the common case mix is based on those initial assessments. But typically the tribe in this type of arrangement, and that's why the tribes want to be involved, is to make sure that that doesn't happen to their tribal members. The tribe's going to want to make sure that it has the ability to offer the services that its members really need. It's also going to want to make sure that it's contracted with enough providers, especially in rural areas, that can provide those services. So if you've got an MCO that's primarily in an urban area, but doesn't have very many service providers and workers out in the back 40, the tribe's probably not going to get the services that they really truly need. So that's where the difference comes in. That's where having that control really makes a difference, because now the tribe's controlling it. And remember, by the tribe controlling it, it takes the financial burden off the MCO, which is a big deal because they do have to stay in business. I know that was a long answer to what should have been a simple question.
No, it was, some of the simple questions have the longest answers. It was a good answer. I think an appropriate final question from Ms. Ladlad is, can we apply as an MCO? As in, is this available for applications now?
That depends on the state. I know that here in the state of Wisconsin, if a tribe wants to, the state is open to that right now. Otherwise, for the other states, that I can't tell you. You'd have to contact your state Department of Health.
All right, fantastic. Thank you so much, Mr. Larson. Thank you, everyone, for joining us. I would like to thank David Larson for joining us today and sharing these resources to help us out about waivers and waiver claims. And in closing, I'd like to remind everyone that today's webinar was recorded and that the audio and presentation slides will be made available online at cms.gov on the Tribal LTSS Technical Assistance Center website. The link should be both in the Q&A answer and in the chat. Thank you again for joining today's webinar, and our session is now concluded.